Good afternoon, everyone. And once again, on behalf of Team ISAR 2021, I would like to welcome all our delegates for this lovely webinar on seed and soil. As we know that we had taken 2 weeks off for a festival reason, and now we are back again. We are continuing with our male infertility portion, and today is a unique program where we will have a ART and male infertility, in which a ART consultant, Dr. Rana Chaudhary, will talk about how to handle male infertility in a clinical scenario. Completed her undergraduation and post-graduation from say GS Medical College, and she has done her masters in reproductive medicine and IVF from UK, the diploma in ART. She is a consultant obstetrician gynecologist at Vocard Hospital, Messina Hospital, Jagjeevan Ram Hospital, and she is in this field for last more than 15 to 20 years. So, Dr. Rana is going to talk about male infertility clinical aspects now, and then we will have the question answer sessions.
I'll be talking today on male infertility and assisted reproductive techniques. We all have seen that during the last 5-6 decades there have been very much advancements in the infertility diagnosis as well as management. But when we look at the live birth rate, somehow we have been stuck up at that figure of 30 to 40%, and as such our pregnancy rates have not gone beyond that. So is there any role as clinicians if we can optimize the gametes, particularly the male gametes, is what I'll be talking about. Like I said, around 15 to 20% of all the married couples throughout the world are suffering with infertility, and the incidence varies from state to state. Like in Maharashtra, we have roughly around 4%, while in Kashmir, it's as high as 15%. And almost 10 to 15% of these infertile men have azoospermia or complete lack of sperms. One fifth of our whole population is suffering from severe oligoastenospermia. Let's go back to the history. Whenever we get stuck up, we should always go back to the history. So on history, there are certain important parameters which needs to be concerned when a male person or a couple comes to us with infertility. Like in females, the age of the male partner is also quite important. There have been recent articles which are talking about paternal aging, which says that men above the age of 45, and particularly those having comorbidities like diabetes, may have abnormal sperms. Also, longer the duration of infertility, more the chances of having an abnormality. Certain professions are quite risky to the sperms, in the sense they can lead to heat and radiation injury to the sperms. Our various lifestyle factors, which we have been telling repeatedly and trying and imbibing in our patients, but then there are not many studies, or we can say RCTs, which tell us that whether it causes an impact on the sperm or it doesn't. So, talking about the optimization, the most important would be the lifestyle factors, treating their obesity, trying and reducing the smoking or tobacco consumption. Is there a role of alcohol and caffeine? We'll see. And there have been certain papers which are talking about increasing the frequency of ejaculation. We all know that the WHO standard semen analysis is the cornerstone of diagnosis of male infertility, and most of us clinicians depend upon this for all. We just do the semen analysis, and once the report comes normal, we say, okay, now the male partner has been ruled out. Now, over a period of time, what we have seen in the last few decades, that the semen count is going down drastically. Like it was 20 million, now it has come down to 15 million, and the progressive motility of all the population is also reducing. But labeling one person as having subfertility or infertility based on only one semen analysis report would not be appropriate. As we know that there is wide variation between the semen counts and also between the laboratories. So whenever you are sending your patient to a semen analysis, you should know that this lab should be a standardized lab which should give you the report in the standardized WHO format. Let's say that the report shows any abnormality, it's very essential that you repeat the semen analysis at least 4 weeks apart, 4 to 6 weeks apart, with a proper abstinence of minimum of 2 days and maximum of 7 days. Also, when you're starting any kind of therapy, let's say that there were too many pus cells in the semen sample and you have given a course of antibiotics empirically to the gentleman, you need to repeat the semen analysis only after 2.5 to 3 months, because we all know that one spermatogenic cycle, that is the formation of the sperms, is anywhere between 60 to 70 days. And again, for the semen to travel from the testis to the epididymis and for the ejaculation, it takes anywhere between 2 to 3 weeks. So, any kind of therapy which you are giving to the patient, we need to repeat the semen analysis only after 3 months to know whether it has acted or it has not acted. IUI is the most common procedure which we do for all our patients for the basic step. Now, many times our IUI cycles do fail, and it's very important to understand that there are certain parameters which will tell us whether this IUI will be successful or not. As far as the semen parameters are concerned, we need a sperm count of at least 20 million per ml with good sperm motility of at least 40%. Now, what do we do in cases of male infertility? Well, in cases of male infertility, giving them oral ovulagens to the wife, like clomiphene citrate or letrozole, has been shown to not increase the success of IUI. It is only when you give them the gonadotropins for the ovulation induction do we get a better quality of oocytes. Also, our target should be to at least have 2 to 3 follicles in that particular cycle. Now, there are some contradictory reports about using a double IUI or a single IUI. We all know that the oocytes and the spermatozoa have a limited period of survival, and the best time for insemination would be ideally just before or maybe maximal 10 hours after ovulation. So, when we do our single IUIs, we generally post them roughly around 36 hours after your trigger. In cases of double IUI, one IUI is done after 24 hours and we repeat it after 40 to 48 hours so that the ovum is nicely surrounded by the sperms when we are doing the IUI. Now, what does Cochrane say? There was a Cochrane review in 2007 of almost 2,000 women, which said that double IUI did have a significant benefit over single IUI in subfertile couples where the husband semen was used. Now, these are the later on meta analysis in 2017, which had almost 4,000 women. They did not find any difference when the sperm semen parameters were almost normal. However, when we added gonadotropins or when we used gonadotropin stimulated cycles, the IUI results were much better in cases of double IUI. Just to summarize, either it should be a single well timed IUI to have a good success rate, but if you have a patient who has have got male subfertility, the semen parameters do not look that good, then probably if we do a double IUI, our success will be much better. Doing it in a gonadotropin cycle will help us. Another important thing which causes anxiety amongst the men is giving the semen sample. Of course, whenever the husband is not available for our IU and IVF cycles, we do a backup freezing. But it is also very important that we take this backup semen sample once we have started the stimulation for our IVF or ICSI patients also. It reduces their anxiety. They are not just told that, okay, on the day of OP or the OM pickup, you have to give the semen sample. Since we have one backup semen sample, we know that the gentleman can give the sample and his anxiety is reduced. Also, the embryologist can beforehand see that semen sample at how the count and motility is. Also, in all cases where you're thinking that there could be a secondary testicular failure, like patients undergoing radiotherapy or chemotherapy, it's a good idea to back up the semen sample, maybe 3 4 aliquots. And also, where you see in a person having low sperm count and motility, and you see that the FSH levels are over a rising trend, so you know that this person can end up with a secondary testicular failure. So it's a good idea to freeze the sample in these patients. Now, we often think that only the sperm count is a very important parameter in deciding the type of therapy, whether it's an IUI, IVF, or ICSI. But more than the count, it's also the motility of the sperms, which is extremely important. And hence comes the entity, the total motile sperm count. There's a very interesting paper in Human Reproduction 2015 which talks about it. So it's basically the total number of motile sperms which are available in that semen sample. Let's say that the gentleman has given us 4 ml of the semen sample with 10 million counts per ml and 50% motility. In that case, the total motile sperm count would be roughly around 20 million. So we have a chart which tells us that what kind of therapy would benefit in this person. So if your pre-wash total motile sperm count is more than 5 million per ml, in that case you can very well plan an IUI. However, if it is between 1 and 5 million, it's better to offer IVF to these patients. And in cases where the total motile sperm count is even lesser, only less than 1 million, then ICSI would be a better treatment option. Now, in spite, when ICSI came, we thought, oh wow, we have got the treatment for male infertility. But in spite of doing ICSI, sometimes we are not getting the pregnancy rates. Either they are ending up in miscarriages or implantation rates are not good enough. Are we lacking something? Are we missing something? So we go back to our semen analysis. Is the semen analysis the only test which is done? Well, actually, it is the routinely diagnostic test. But what studies have shown that up to 40% of infertile men do have absolutely normal semen parameters, which are within the WHO range. So we need to do something else like the sperm function test. One of these important sperm function tests is the hypoosmotic swelling test, or the HOS. It basically tells us about the integrity and the behavior of the cell membrane of the sperm cells, and hence is very important in men presenting with adenosospermia. It helps us to distinguish between the sperms which are immotile and live and the dead sperms. So all those sperms which are immotile but their live sperms will show curling of the sperm tail. So we can offer ICSI in these particular men. However, if there is no curling, which means that the sperms are absolutely dead, they have not taken in the reagent. In that cases, maybe testicular sperm extraction can be tried. And even if that does not show any sperms, then donor sperm will be the only option remaining for us. The other is the development of the sperm DNA fragmentation assays. Now, basically, sperms have the function of transporting the complete haploid genome to the ovum, and during this process, there is controlled DNA nicking and DNA compaction. Now, in infertile women, what studies have found that there was increased DNA fragmentation, which was because of either various extrinsic or the intrinsic factors. There could be abortive apoptosis or defective maturation of the sperms, getting them more predisposed to this kind of disintegration and fragmentation, which presented as infertility, repeated implantation failures, or in sometimes even genetic or birth defects. Now, what are the extrinsic factors? Suppose the sperm stays in the testicular system, that is in the epididymis during this transit for a very long time, or the person has got varicocele. All these conditions increase the oxidative stress. Also, environmental factors like various drugs, smoking, pollutants, diabetes may cause an adverse effects. Why are the sperms more susceptible to this oxidant damage? Well, they have large amount of polyunsaturated fatty acids in the plasma membrane, and hence they are quite susceptible to this oxidative damage. The supraphysiological levels of the reactive oxygen species overwhelms this protective antioxidant system and therefore results in the sperm DNA strand breakage, which is seen as fragmentation. Nowadays, there have been various tests which are used for the diagnosis. We have your direct test using probes and dyes, and the indirect tests like the sperm chromatin assays, the tunnel test, the comet test. Now, have we really found the test which will be able to tell us whether the sperms are good or they are not good, or how do we go about it? Well, most of the studies are still quite ambiguous in this, but we have found that there are high levels of sperm DNA fragmentation in men with abnormal serum parameters, and also in normosomic partners of infertile couple. So I would say that doing a sperm DNA fragmentation test is complementary to doing a semen analysis. Where all now, coming back to the studies which tell us how it will help. Now, this was a Danish study which found a correlation between infertility and the sperm DNA fragmentation index. It said that men who had normal semen report but had high DNA fragmentation index had a longer time to achieve natural pregnancy. This was basically a meta-analysis looking at the results in IUI. Now, there are a few studies from 2002 to 2016 which say that whenever the sperm DNA fragmentation index was quite high, there was either a reduction in the pregnancy rate or it had a negative impact on your IUI pregnancy rates. There have been a meta analysis of 16 cohort studies involving more than 3,000 couples. And in this, they found that men who had increased sperm DNA fragmentation index had decreased pregnancy rate when they underwent an IVF cycle. However, this was not significant when they did the ICSI cycle. Now, how could we explain that? Probably when both the gametes are subjected to prolonged culture and exposure to the oxidative stress, like in our IVF cycles, probably the oocyte is not able to repair it unless in ICSI. In ICSI, if you have a good quality oocyte, which are lesser exposed to oxidative stress, because of ICSI, in spite of the high DNA fragmentation index, the ICSI patient had better pregnancy rate. This could be possible one of the explanations for the high pregnancy rates. Now, there is another recent study in 2019, which was basically a retrospective study of more than 2,600 ART cycles. They included all your IUI cycles, 1,200 IVF cycles, and 200 plus ICSI cycles. What they found, they graded the sperm DNA fragmentation into high, medium, and low, and they found that overall the clinical pregnancy rate is not that significantly different, but the chances of having an early abortions were much higher, significantly higher when we had sperms which were high DNA fragmented. So basically, the same study, when we looked into the IVF and ICSI cycles, it said that it did not affect the oocyte fertilization or the good quality embryos or even the clinical pregnancy and the abortion rate. But they did find that increased age, longer the abstinence, and unhealthy lifestyle did cause an increase in the sperm DNA fragmentation index. So we now understand that high sperm DNA fragmentation is one of the factors which can affect our pregnancy rate, which can affect increase our chances of miscarriage, and therefore we are looking for treatment which could reduce this sperm DNA fragmentation. Although in literature there is still lack of effective evidence, but various therapies have been proposed, like your oral antioxidants, varicocele repair, recurrent ejaculations. Let's see what the literature says. If we shorter the ejaculatory abstinence, by which I mean if the person ejaculates in every 1 or 2 days, the transit time, the time during the epididymal transmit from the testicular sperm reduces, and hence the exposure of the sperms to the ROS reduces. This reduces the oxidative stress on the sperms and improves your sperm DNA fragmentation. There's a Cochrane review of 2014, which included 34 RCTs and around 3,000 couples, which said that the live birth rates and the pregnancy rates did improve after using oral anticoagulants, and the sperm DNA fragmentation went down. Well, the miscarriage rates could not, there was no effect on that. It was not statistically significant, but yes, it did improve the live birth rate and the pregnancy rates. Now, which antioxidants to use? You have a whole plethora of antioxidants, mitochondrial energizers, and some nutritional factors. The good thing to recommend would be a combination therapy of preferably mitochondrial energizers and free radical scavengers like your CoQ, lycopene, vitamin E. For varicose surgeries, we all know for the grade 1 and grade 2, we do not generally recommend any varicocele surgery. A trial of medical therapy in the form of antibiotics, antioxidants are given, followed by maybe 3 cycles of an IUI. What are the positive predictive factors when you think that yes, this varicose surgery will help the person and it will improve the sperm count? Well, first of all, there should be lack of any testicular atrophy. The FSH level should be normal, and the total sperm count before the surgery should be more than 5 million per ml. Now, which are the conditions? I'm so sorry. Which are the conditions where you would recommend doing a surgery in spite of a lower grade? For this, we can do the sperm DNA fragmentation test. When you have a grade 2 and grade 3 varicocele with a normal conventional semen parameter, it's a good idea to do the sperm DNA fragmentation test, which will help us to know how much is the damage to the sperms. Also, in case of grade 1 varicocele, where you have a borderline or abnormal semen analysis report, it is always better. This is a systematic review published in 2012, including 12 studies where they had patients with clinical varicocele and compared it with the control group. They found that there was high sperm DNA fragmentation in all the men having varicoceles, and after surgery, 37% of them conceived naturally and 24% after ART treatment. So we have gone through the antioxidant treatment, the sperm vitalizers. Of course, we give antibiotics if there is infection in the semen sample. Coming to the hormonal agents which can help. We have various hormonal agents like your androgens, anti-estrogens, aromatase inhibitors, and of course the gonadotropins. In hypogonadotropic hypogonadism, we do use HMGs, recombinant FSH, and HCG. HMG in a dose of 75 international units, recombinant FSH 300 international units daily, and HCG 1500 to 3000 international units every fifth day. Androgens can be used in hypogonadotropic hypogonadism like testosterone and decatonate intramuscular injections. For men who are overweight and have got low testosterone and estrogen ratio, letrozole aromatase inhibitor has been found to be quite beneficial. Now, most of these drugs are used currently off-label. There is no proper RCTs which are conducted on their efficacy, but then we have been using it, and in some patients we have been getting good results with it. Although gonadotropin subcutaneous infusion pumps are still just available in trial centers and specialty clinics. Another aspect is the surgical retrieval. When you have varicocele, of course, you'll be doing the microsurgical varicocelectomy. In men having past vas deferens surgery, tubal anastomosis can be offered. And the important aspect is the sperm retrieval techniques. Now, these testicular sperm or the epididymal sperms can be retrieved when you have an obstructive azoospermia with normal FSH, or even in cases of non-obstructive azoospermia, where they can be in certain areas of focal spermatogenesis. In very few patients, if they have failure to ejaculate in spite using a vibrator or an ejaculator, sometimes the testicular sperm retrieval is required. In cases of non-motile sperms, the HOS will help us to identify the better sperms for using for ICSI. But in cases where you have completely immobile sperms which are non-viable, sometimes when you do aspirate the sperms from the testes, they are sometimes motile also, and hence it can be one of the therapeutic options. We have various techniques by which the sperms can be aspirated either through the epididymis or the testes, like your MESA, TISA, and PISA. Now, what does Cochrane say regarding the different sperm retrieval techniques? The meta analysis of 2008 says that currently there is insufficient evidence to recommend any particular sperm retrieval technique. So, we should go ahead and plan the simplest and least invasive technique for our sperm retrieval. For obstructive azoospermia, maybe doing a PISA, and if your percutaneous epididymal sperm aspiration fails, then probably doing an open needle fine aspiration biopsy or a needle aspiration biopsy would help. In your non-obstructive azoospermia, a needle aspiration biopsy will definitely help. If 6 to 9 needle aspiration biopsy from each side fail to produce adequate sperm, then multiple microsurgical biopsies, that is single seminiferous tubules bilaterally, can be used, or else we need to take micro TC. So it should be basically starting with the simplest and the least invasive techniques. Now, in cases you have non-azoospermic as non-obstructive azoospermia, there is absolutely no role of using an epididymal sperm retrieval techniques. Now, in cases of total azoospermia, their needle aspiration biopsy is preferred as compared to the epididymal sperm, because, like I said, the sperms in the epididymis have got more DNA fragmentation, and hence it is not worth doing it. In cases of non-obstructive azoospermia, it is worthwhile that we call a urologist who could perform a microdissection TC or single seminiferous tubule biopsy. Like I said, there are various recent studies like papers in 2017, also in Fertile Sterile 2015, which to say that the testicular sperms are much better as compared to the epididymal cells. They have got 3 to 5-fold lower sperm DNA fragmentation, and hence the live birth rates, as you can see, are much better when you are using testicular sperms and providing ICSI. It was 49% as compared to your using the other sperm selection methods like your IMSI and PICSI. So all couples who had previous ART failures having severe oligoacidonisospermia should we should recommend having testicular sperm ICSI. The laboratory factors have already been covered by Dr. Ramesh. Now, once all our we have tried everything for sperm optimization and still we are not able to get good quality sperms, is when we look for donor sperm, therapeutic donor insemination. It can also be used in cases where there have been repeated failure to fertilize previously, there have been significant genetic defects, or the women shows features of isoimmunization. How do you procure a donor semen? Well, as far as the ICMR guidelines of 2005 state, a relative or a known friend cannot be a sperm donor. It is the responsibility of us clinicians to obtain sperm from an appropriate ART bank. It should be an anonymous donor. We can know the basic characteristics of the donor, like the height, weight, age, complexion, educational qualifications. We can charge the couple for the semen provided and for the test run. What are the requirements? He should be ideally between 21 to 45 years of age with normal semen analysis report. We do the viral markers. The person should be free from all your viral infections like HIV, hepatitis B and C, chronic illnesses like hypertension, diabetes, STDs, or any other identifiable and common genetic disorders like thalassemias. These are the donor consent forms, which are also very important when you are using a donor sample, either for an IUI or for an IVF or ICSI, which clearly states that the child which is born out of this will be the legal heir of the couple. I'm sorry, will be the legal heir of the couple. And there are also increased chances, marginally increased chances of abortion and multiple pregnancies when you are using any kind of ART techniques. To conclude, I would say that IVF and ICSI is not for all. We should be doing a meticulous semen examination from a standardized lab only. There is certainly some relationship between sperm DNA fragmentation and the reproductive outcomes, which needs to be explored by further studies. And probably using a testicular sperm rather than an ejaculated sperm may be beneficial in men who have got severe semen abnormalities like severe oligoacinospermia, high sperm DNA fragmentation index, and recurrent IVF failures. Lifestyle factors need to be repeatedly addressed as they play a very vital role in the sperms. Thank you, everyone.